So the fundamental physiology of CAH is very easy to identify, but it's very important to know the nuances of each pathways because that determines the various manifestations that we have. And we'll discuss one by one in a reasonably succinct manner to cover the entirety of this whole pathway. So as discussed, when we talk about CAH, we know that the overall process is regulated via the hypothalamic corticotropin releasing factor or corticotropin releasing hormone, which regulates ACTH, which regulates adrenal production. Now, there are three specific adrenal hormones. Cortisol is produced by around 10 milligrams. We can say 6 to 8 milligram per meter square per day is the usual endogenous production rate of cortisol. DHEAS is the most abundant steroid. It's around 15 milligrams. And we have got aldosterone, which is 0.1 milligram. Now, which other steroid in the body, I'm not talking about adrenal, is produced in huge amounts, much higher than these as well? But it is produced only in sometimes, not always. So what I'm asking is that which gland is producing equivalent amount or if not more amount of steroids in the body as adrenals? And it may be not even a gland, a small part of that gland. Manoj? And that production is huge. So how much testis will produce testosterone? Testosterone is usually not. And that happens in one of the genders in specific times. So one of the most hyperactive steroid producing gland is actually corpus luteum. Corpus luteum produces huge amount of progesterone. So when it is producing progesterone, it is actually more than the adrenal production because progesterone levels go really high. So that is the exception, but otherwise the adrenals are the most important. Now, what we are seeing is that there is a discrepancy between the amount of cortisol which is produced compared to aldosterone which is produced. So cortisol is produced 1,000 times more. When you see these linear pathways, you will say, okay, everything is equal. This is producing cortisol, this is also producing androgen, this is also producing aldosterone. But remember that you have got 1,000 times greater production of glucocorticoid than mineralocorticoid. So which deficiency is more likely to manifest glucocorticoid or mineralocorticoid, Manoj? If you have a deficiency, and when we talk about deficiency, it's not absolute. It's a variable spectrum. So considering that cortisol production is much higher compared to aldosterone production, deficiency of which compartment is more likely to manifest? Is it aldosterone or is it cortisol? Cortisol will be more affected because there, even if you have some less production, you will know it. While for aldosterone, you only need 0.1 milligram. So that deficiency will not be manifested early. That is the fundamental basis of what we know as is simple virilizing form of CAH, in which you have cortisol deficiency, but you have reasonably enough amount of aldosterone production, which will take care of. So this relative production is also very important to understand. Now, in that perspective, when you have cortisol deficiency, your ACTH will go up, the adrenals will become big, and you will have other hormone effects which will happen. So congenital adrenal hyperplasia, if you remember the pathway, all you have to remember what is distal to that pathway, there will be deficiency of that, and what is proximal to that pathway, there will be excess of that. This is very, very simple in that perspective, and we can then decide what aldosterone and this thing happens. So now if we talk about the adrenal production, we all know that cortisol is a major hormone along with DHEAS, which is mainly produced during puberty. So before puberty, you do not have that much DHEAS, and aldosterone, of course, is important. There are different zones in the adrenal, glomerulosa, fasciculata, and reticularis, which have differential enzyme expression. Now, what decides whether one particular cell will produce aldosterone or cortisol or androgen as a final product?
It basically depends on the electrons.
Yes.
Because certain enzyme activity requires.
So which is the crucial enzyme which decides everything? So 17-hydroxylase lyase activity in a way is a main determinant. If you have got no 17-hydroxylase lyase, you will produce aldosterone. If you have got hydroxylation predominant with no lyase activity, you will produce cortisol. If you have both activity, you will produce DHEAS. So the main branching enzyme, which we'll discuss later on, is 17-hydroxylase. And now why does 17-hydroxylase behave in that manner? Is the electron availability. You need electron donors. So if you have too much electrons, you will complete the whole cycle and you will produce DHEAS. If you have less number, you will produce cortisol. If you have no number, you will produce aldosterone. And this brings us to a very interesting scenario. You always have ACTH in the body. Why is it that DHEA starts getting produced only during puberty? So you produce aldosterone, you produce cortisol. Why don't you produce DHEAs? For gonadotrophin and for all the other pathway, we know gonadotrophin is not there, so testosterone is not being produced. But here, why does the adrenarche happen all of a sudden? So what is the trigger for adrenarche? So, but how does the bone age mediate adrenarche? How does the body realize that now we should push, or what change starts adrenarche? So these are all the signals. But then what is the switch? The switch basically is the electron donors. So when the electron donors go above a particular level, you will have increased DHEAS production. So all mechanism is there to produce DHEAS. It is not being produced because you don't have that much electron. So this is an important concept to remember. And of course, we discussed about progesterone, which is produced by huge amount via corpus luteum. Now, Vibha, out of these 4 steroids, catecholamine is of course not a steroid, it's an amine, cortisol, aldosterone, DHEAS, and progesterone, which is the most important for sustenance of human life? Progesterone. Why?
Progesterone was to hormone that is important for the viability of the.
So if there is no progesterone, your uterine contractility will keep on continuing and you will have abortion, which will happen. Implantation will be defective. That is why we talk about luteal phase defect, in which a lot of progesterone supplement is given. So for fetus to continue, you need progesterone. Otherwise, you may have 0 cortisol, you may have 0 aldosterone, and of course, DHEAS is of no consequence per se. You will still be having a normal baby. That is why somebody with CAH is absolutely normal. He has no production of cortisol, but still mother is taking care of glucose. He has no production of aldosterone. So maternal, all the hemodynamic instability, sodium, potassium is taken care by the placenta. So the most important is progesterone to ensure the survival. That is why if you have complete side chain cleavage defect, you will never have a viable fetus. And in fact, earlier books used to say that if you have side chain cleavage defect, it will never manifest postnatally. But now we know that milder defects in which some progesterone is produced can manifest. So this is of course a spectrum which can produce. So most important of course is progesterone. Steroidogenesis, it happens in a way in which there is a syncretism. So there are a lot of organs which are going to be involved. The major organelles which are involved in steroidogenesis are the mitochondria and the endoplasmic reticulum. And there is an exchange. Now this is a very interesting phenomena. So there is a shuttle which keeps on happening within the endoplasmic reticulum to the mitochondria and back, and then they decide to produce which ones, because the enzymes which are expressed are different in both cases. So cholesterol, of course, will come from the blood, or some of it will be produced inside the cell. It will then be pushed into the mitochondria via STAR, which we'll discuss much more in detail, the Styrogenic acute reactionary protein, where you have a number of enzymes, largely hydroxylases. So you have 11A1, which is the side chain cleavage, which is there. Then it is shifted back to the endoplasmic reticulum. So remember this, and we'll come back to this when we talk about the whole pathway. So initial step is happening at the level of the mitochondria. Then your product will go directly for 3-beta-HSD within the endoplasmic reticulum, along with you have 21A2, which is there, and 17. So all these activity will happen within the endoplasmic reticulum. Then from there, you will shift again back where you will have the 11B1, which is responsible for cortisol synthesis, aldosterone synthesis. Both processes will ultimately happen within the mitochondria. Now, in the endoplasmic reticulum, if you do not have 11, you will not produce cortisol, you will not produce aldosterone. So all you will produce will be a DHEAS, which is produced. So specifically, if we talk about mitochondria is the main source for cortisol and aldosterone, and endoplasmic reticulum is the main source of DHEAS in that perspective. Now remember, for all of these processes are largely either oxidation or reduction. So when we do oxidation and reduction, you need an electron donor, which will give you electron or will receive electron. So there are specific things like POR, oxidoreductase, which plays a role in the endoplasmic reticulum predominantly, while you have adrenodoxin reductase and NADPH, which plays a role in the mitochondria. Now, based upon this, what is interesting, Naveen, you will find is that what will be the manifestations of POR defect, oxidoreductase?
The POR is basically subject to many key enzymes.
So it is not, it's not the subset, it is an electron donor.
Responsible for the activity of the
Hmm.
So as I said, when the aromatase and one is the
17 and 21 and aromatase. So this is, if you talk about enzyme defects, you have single defect. The problem is there and the manifestations is there. But if you have problems in NADP, if you have problems in POR, multiple enzymes will be affected. So you will have a very confusing clinical picture. That's why POR may present you with virilization because of aromatase deficiency, under-virilization because of 17-hydroxylase deficiency, salt wasting, which will be because of 21. But the manifestations of these will be milder compared to any of these individual forms. So 17-hydroxylase will be more severe, 21-hydroxylase will be more severe, aromatase deficiency will be more severe. But if you have POR, you will have a milder picture of all three. So it's like a confusing, complicated picture. On one hand, you have got more androgens. On the other, you have got less androgens. So a lot of confusions will be created because of POR in that regards. Now, we need to understand one basic principle as far as chemistry is concerned about oxidation and reduction, because most of these enzymes are either oxidase, reductase, and this is something, and hydroxylase. Hydroxylase will ultimately also act in a different fashion. So what really is oxidation and what is reduction? So when you convert iron into oxide, it is an iron oxide to iron is reduction. So what you really mean in very basic chemistry terms regarding what is oxidation?
Maybe the gain of electrons is the oxidation and the loss of electrons is reduction.
Okay. So basically, if you are gaining an electron, you're becoming negative. So that basically would mean that you are getting a product which is reduction and not oxidation. So you need to be more clear in that perspective. So for reduction to happen, you would need an electron which is donated. So if you are converting yourself there, then you become reduced. The opposite of this will, of course, be oxidation, where you give your electron to another compound and then you go towards that direction. So, and usually these processes are bidirectional. So you will go in either this direction or the other direction. Why are they bidirectional? Because if you have a particular substrate which is high, you can then convert it into towards the other side. So now, Manoj, when we talk about enzymes, we discussed about this oxidation reduction. Bidirectional processes are relevant for which group of enzymes? So there are broadly two groups of enzymes which we talked about: hydroxylases, 21, 17, side chain cleavage. These are all hydroxylases. And then we have hydroxysteroid dehydrogenase, 3-beta-HSD, 11-beta-HSD, 17-beta-HSD. Which one of these are bidirectional? Okay. Naveen?
Sir, 3-beta-HSD, all the beta steroidogenesis generally do not require the electron and they are bidirectional, whereas these hydroxylases are unidirectional and they require.
They need a specific active input. So they go in that direction. So if you now remember 11-beta-HSD1, which is basically converting cortisone to cortisol, it is actually a bidirectional one. When your cortisol level is low, it will activate and produce more cortisol. But when you have too much, it will work in the other direction to prevent it. So that's why I mean is bidirectional. It can go in both directions from that perspective. So if your donor is more, you will go more towards the reduction process. If your recipient is more, you will go more towards oxidation. So this will depend upon the environment. So what I'm saying is that these steroidogenic defects are not just because of enzyme defects. There are also issues of substrates. There are also issues about cofactors. So now we know about NADP problem. Now we know about G6-PDH problem, which we'll discuss subsequently. Now we know about POR. So it's not just the conventional enzymes, it is the other cofactors which also play an important role in pathogenesis. And this is something to understand. So usual donor is NADPH and recipient is NADP+. So simply speaking, if you get a H, along with that, you are getting reduced. This is what simple thing. So if you have a ketone and it becomes enol, O becomes OH, it of course is getting reduced in that perspective. And POR and ADX are also the other electron donors in that perspective. So as discussed, there are two basic types of enzymes in the steroidogenic pathway, P450 oxidases and hydroxysteroid dehydrogenases. So P450 are the hydroxylases basically. So when you say oxidase, they are also hydroxylase, the same meaning. So they have heme group. And why do we call P450? Because their absorption is highest at 450 nanometers. Now, this is a very, very common type of enzyme. A lot of enzymatic activity happens through P450. We all know about that. Now, they do not have isoforms. This is very important. Why does having isoform get important? What do you mean by isoforms?
Previous one, like one.
No. What is an isoform? So you have got one type of enzyme which is there in the adrenal.
The enzyme is working here if one takes and another type is working at different.
So you have similar enzymes which are expressed by other organs. You have 3-beta-HSD2, which is there in the adrenals, but you have 3-beta-HSD1, which is there in the liver, placenta, and other places. So there it will express. So if you have isoforms like hydroxysteroid dehydrogenase, the manifestation of the disease changes. Can you give an example?
If there is this 3-beta-HSD deficiency, there is virilization occurs in the.
So you have 3-beta-HSD deficiency, you are saying. So theoretically, if you have got no 3-beta-HSD, you should have no androgens. But yet the females get virilized.
Because there is another isoform 3-beta-HSD1 in the liver, it gets
So you have peripheral isoform. So if adrenal is deficient, peripheral is less efficient, but it will produce some amount of androgens. So that is why you have got so high levels of DHEAs, it will get converted into androstenedione, it will produce testosterone. So isoforms make it important that you will never have absolute deficiency. You will have partial deficiency and this will cause problems. So 3-beta-HSD2 deficiency, that's why will cause virilization in females, plus also causes under-virilization in males because you don't have that high levels. So you, instead of 0, have a testo of around 50-60. But you will never have a testo of around 200-300, which is important. I think this is an important message to consider. The other thing to remember, of course, is that this is hydroxylases. We discussed about 11, 21, aromatase, 17. These are all hydroxylases. And then 3-beta-HSD, 17-beta, 11-beta. The most important raw material for steroid production is cholesterol. Cholesterol can theoretically come by endogenous production, which is the HMG-CoA reductase, or from outside. Now, we know that the major source of cholesterol is actually from the outside, which is coming via the LDL pathway. Now, this cholesterol has to be pushed into the mitochondria using STAR, which are the hormones which regulate STAR activity, organ specific. Manoj. So first of all, you tell me, the regulation of steroid is at the level of synthesis or release?
Steroid at the level of synthesis.
Why?
Because slowly produce on the basis of the requirement.
Anything else?
And it having the binding protein also.
Binding protein? What are steroids? These are lipophilic or hydrophilic?
Hydrophobic.
Lipophilic. So won't they escape the membrane? If you have too many criminals who can run away from the jail, why are you keeping so much? So they will produce only when the requirement is there. Plus, the process is not that complicated. So what you are saying was a bit opposite. When you produce a protein, you need a much more significant process to produce. So that's why you produce them and store it. So if you have insulin, if you have PTH, if you have any of the protein hormones, you will store in the vesicle and then you release. So their regulation is mainly at the level of release. Steroid hormones can be produced immediately, but they cannot be kept because they are lipophilic, they will escape. You can't stop it. So you will regulate their production as need. If needed, you will produce. So that's why the production happens. Now, what I said was that the initial step happens in the mitochondria. The side chain cleavage enzyme starts acting in the mitochondria. So to push that, you have got this star which will push it through in that perspective, and then steroids are formed from that perspective. But remember, the endogenous production is less significant. Why is it important clinically? Suppose internal production was a major factor of steroid synthesis. What will happen when you're treating some patients?
So in case if you're treating with HMG co-inhibitor inhibitors such as statins, then there will be
Then everybody will develop adrenal insufficiency. If you're inhibiting HMG-CoA and the major source is internal, they will develop adrenal insufficiency. So the fact that that does not happen means this HMG-CoA production is a mild player in that regards. The most important player, of course, is, we discussed it hugely when we talked about lipid, is the LDL and the LDL receptor associated protein, which will then carry forward. Now, this peripheral production of cholesterol comes from 7-DHC using DHC7, which converts it into LDL. LDL is accepted using the LDL receptor, and we talked about the LDL receptor associated protein and all those things in that perspective. HDL also plays a role. Now, cholesterol is also lipophilic or hydrophilic. So how will you ensure that it does not escape?
we need to put it in sulfate.
So you bind it basically. So remember, the problem is that if you have too much cholesterol in the cells, it will escape. So you make it that you are binding it with, basically you are tying it in chains, so to speak. And that tie happens using sulfation. Sulfation is a standard process after which it will not escape. So to make it permanent, this also happened in HDL. You remember we talked about LCAT, which does the same thing, acyl transferase. So this converts cholesterol into cholesterol sulfate. This enzyme, we can have two-way pathways again, esterase and lipase. So one which will convert into a ester and one which will convert into a lipase. So if you have a lipase problem, we'll try to do pathophysiology also here. So if you have a lipase problem, what will happen?
Whenever it is required, whenever we require the cholesterol for the secreted steroid, it will not happen.
So you will have, if it's a very severe defect, you will have no production of steroids. So you will have adrenal insufficiency. Then what will happen?
And this cholesterol, the sulfate will attract the calcium inside, and this will cause calcification, and this is the volume.
So you will have adrenal calcification, hepatosplenomegaly, because whichever places you have got cholesterol, it will become deposited. You will have adrenal calcification, adrenal insufficiency, massive hepatosplenomegaly, bone marrow will show macrophages which are fat-filled. This is classical picture of Wolman syndrome. This is the autosomal recessive form. What are the manifestation of autosomal dominant form of lipase defect? So when both genes are gone, you have Wolman syndrome. When one gene is gone, what does that happen? How will it present? This we discussed when we talked about the lipid disorder. It will present more like non-alcoholic steatohepatitis differential. There is mild hepatomegaly, high SGPT, high triglyceride, but it is not a huge level. So lipase is very, very important. If you are not, so it's basically something like you have put in the bank, but you can't use it anymore. Something like demonetization. So you've got all the store in the bank, but you can't use it. So that's why you are hungry. But this money is causing problem because of accumulation in that regard. Same as we discussed about all the GSD0 defects and all those defects when you are glycogen storage disease, when you can't get it out in that regards. Now, HDL plays a minor role, but an important role in the development here. And this HDL transport happens via a transporter called CLA1. Now, CLA1 is very, very important from an adrenal perspective because it provides the effect of two important factors which cause adrenal insufficiency. Which are these? So basically, NRAF51 is the one which causes stimulation of CLA1, and DAX1 inhibits it. So if you have a problem in either of these pathways, you will have reduced HDL induced transport of lipids causing steroid deficiency. So if you understand this, you have got many pathophysiology coming into the picture. You have got this lipase problem. In the severe form will cause Wolman's disease. Milder form will cause the milder defect, which is basically associated like a steatohepatitis. You have got the NRF51, you have got adrenal insufficiency, gonadal deficiency, DAX excess. Again, the same scenario will happen in that perspective. Yeah. And if you have 7-DHC problem, you will have Smith-Lemli-Opitz syndrome, in which you've got no lipids. Basically, everything will become low. Now, we discussed that the first step of steroidogenesis starts from the mitochondria. And for that, the cholesterol has to go into the mitochondria. We all know that cholesterol is a lipophilic one, so it will go to the mitochondria itself. You don't need to have an active transporter. But it will happen at its own pace. And you don't want it to happen very quickly, otherwise all the cholesterol will go to the mitochondria. So body has put up a specific switch, which switches on when needed to push this rate of cholesterol transfer. And this particular switch is known as STAR, Steroidogenic Acute Reactionary Protein. All that STAR does is it speeds up the raw material which goes to the mitochondria. So normally, if your factory is working slowly, one of the limiting factors may be that you don't have that much raw material. So this is just a supplier of raw material. So what are the hormones which induce STAR production? Yes? Yes. So it will depend upon where steroid is to be produced. So if you talk about adrenal cortex, ACTH regulates STAR production. If you talk about testis or theca cell, it will be LH. If you talk about medulla, you will talk about the angiotensin, the aldosterone, the zona glomerulosa, then you will have the ANG2, which will play a role in that perspective. Now, STAR speeds up the cholesterol delivery. Now, if you have a STAR defect, you will have a two-hit model, and this we'll discuss in much more detail when we talk about STAR deficiency. One, your rate of steroidogenesis will become 1/6. So it will become 14% of normal. That, of course, will cause deficiency, but not extreme deficiency. Because when we talk about 21-hydroxylase deficiency, we know that even if you have 5% activity, you will have no problem. Only if you have less than 1% activity, you will have a salt wasting one. So 14% is okay. But the second hit, basically, which happens in that regards, is the accumulation of cholesterol. And this accumulation of cholesterol will cause burst or death of the cell. So this is a two-hit model, and the second hit will happen a bit later. Now, when will the second hit happen will depend upon the steroidogenic capacity of a particular cell. Fetal testes are extremely active in the newborn period, in the fetal period also. So they will be knocked off. Fetal ovaries are silent. They have a lot of oocyte activity, but they do not have a steroidogenic activity. So ovaries will remain normal till 13, 14 years of age. They may actually produce some estrogen, and this happens every cycle. So it's not that the entire ovary is producing that. It happens every follicle is produced. So you may have enough estrogen to produce in STAR defect in females to cause breast development. Rarely some withdrawal bleeding or estrogen withdrawal bleeding may happen, but you have a late manifestation. What about adrenal manifestation? How would you compare adrenal manifestation of STAR defect versus salt wasting in 21-hydroxylase?
It would be the late presentation because of the non-adrenal will start working after 2 to 3 weeks.
So the definitive zone of adrenal is not active in the fetal period. The fetal zone will go. That is different, but you're not bothered about fetal zone. The definitive zone or the adult zone will start acting immediately after birth, not 2 to 3 weeks, but immediately after birth. You present with salt wasting after 2 to 3 weeks because maternal transport and all those things take care of it. But now here it will be further delayed by 3 months, 4 months. And sometimes, as you saw in that child, STAR may actually present like so late, 5 years, 6 years, if it is a milder defect in that. So it's a two-hit model. Now, can you tell me some other two-hit models in endocrinology? One, we have talked about STAR. What is? Neurophysin 2 defect in diabetes insipidus. So congenital central DI has a late presentation because of this. Second,
Second will be a insulin one gene.
So pro-insulin defect, where your pro-insulin is getting accumulated and damaged. So this is a well-known two-hit model which affects many of these conditions, which explains the later manifestation compared to the earlier presentation in that regards.